Welcome to AETCM, the emergency medicine channel. Today let us discuss about hyponatremia and its management in emergency room. Hyponatremia means the sodium levels in our blood is less than 135. Normal value is being 135 to 145 milliequivalents per liter. There are two important types of hyponatremia. One is true hyponatremia, other one is pseudo hyponatremia. Pseudo hyponatremia normally occurs in patients who received high dose of blood sugar like dextrose, mannitol, or very high levels of cholesterol, hyperproteinemia like multiple myeloma. All these things you can get pseudo hyponatremia. But real hyponatremia means the actual sodium level in your blood is low. But whereas in pseudo hyponatremia, some other compartment of the body fluid is increased. So there is only a relative reduction in the sodium in lab investigation, but actual body sodium is normal. Now you can see here three important types of true hyponatremia depends on your body water level. You can see the first test tube with normal water and normal sodium. Second test tube, you can see what you are seeing is a normal water with low sodium. So water level is normal, but sodium levels are very low. That is actual hyponatremia. But in third test tube, what you are seeing is the amount of water is increased, so that relative reduction in the sodium is seen in the lab investigation. Actually, this is also a type of pseudo hyponatremia. Here water level is increased, sodium is normal, but lab investigation shows that there is hyponatremia. Actually, patient will not have any clinical finding because of this type of hyponatremia. This is called as hypervolemic hyponatremia. Third one is low water, low sodium. Both are low. Body water is low, sodium is also low. So that is hypovolemic hyponatremia. So depending on the body water, we have three important types of hyponatremia. One is normovolemic hyponatremia, hypervolemic hyponatremia. Actually, there is no hyponatremia here, only volume is increased here. That's why we are getting relative hyponatremia. Third one is the hyponatremia is there and hypovolemia is also there. So depending on this body volume situations, the treatment also may vary. Like a normovolemic hyponatremia, you have to correct only the sodium levels. Whereas hypovolemic hyponatremia, we have to correct both volume and sodium. Whereas in hypervolemic hyponatremia, we have to only reduce the volume expansion in the body. So we can see the causes. The important cause for hypervolemic hyponatremia that we can see first, increased extracellular fluid. All types of failures, like whether it is cardiac failure, liver failure, renal failure, nephrotic syndrome, anemia or hypoproteinemia, all these conditions, body volume will increase. So advantage of learning this condition is there is no need of treatment of this condition with sodium. We have to only remove the fluid from the body. If you want to correct the sodium, only remove the volume from the body. And even if you don't remove the volume from the body, hyponatremia as such will not create any problem in the patient. But whereas the volume expansion can have so many problems, like cardiac failure can occur, breathlessness can occur, pulmonary edema can occur. So that problem should be tackled. Whereas in hyponatremia with low ECF, that is hypovolemic hyponatremia, we have to correct both volume and sodium levels. Both should be corrected. So we can correct with normal saline, so that contains volume, that also contains some amount of sodium, but sometimes patient may require normal saline with 3% saline or normal saline with added salt, like that. Whereas the first one, what you are seeing here is, in this slide, is hyponatremia with normal ECF volume. In that, most important condition is SIADH, syndrome of inappropriate antidiuretic hormone secretions. Here we are having a problem, that is volume retention is there, but we are not seeing clinical edema. That is very important. patient is having actual volume retention in the body and hyponatremia is there, but on clinical examination you don't see any hypervolemic signs like pedal edema will not be there. There will not be any peripheral edema in this patient, but inside the cells there is water retention. So that is hyponatremia with normal ECF volume, but even when we tell it is normal ECF, there is some amount of water retention is there, especially in conditions like SIADH, hypothyroidism, all these things. Now we can see what is SIADH, that is syndrome of inappropriate ADH secretion, persistent ADH release, and that leads to water retention. That is the most important problem. Water retention is the most important problem. You can see so many conditions including lung malignancy, CNS diseases like meningitis, chronic meningitis, and some drugs, post-surgical condition. All these things can produce SIADH. Whatever it is, SIADH means increased ADH release. That produces water retention. But what we have to remember is, even if it is water retention, there is no clinical findings of fluid overload. That is very important. Water retention is there, that produces hyponatremia, but that will not produce any clinical signs of hypervolemia. Now you can see the clinical feature of hyponatremia. The problem in hyponatremia is it mainly affects the neuronal cells. The shift of the water from one side to other because of hypernatremia or hyponatremia, the main problem occurs in the central nervous system. That produces all the complications of hyponatremia. So that will increase the volume of intracellular fluid, especially in the brain cells, that lead to brain edema. So hyponatremia normally produces brain edema. So depending on that, you get all the clinical findings. So patient can have anorexia, headache, nausea, vomiting, weakness, personality changes, altered behavior, low GCS, muscle cramps, muscle weakness, confusion, ataxia, drowsiness, diminished deep tendon reflexes, and ultimately if you don't correct it, the patient may develop convulsion. So patient can develop coma, then convulsion, then death. That is a normal clinical deterioration pattern you see in patient who is having hyponatremia. Now whenever we have a patient who is having hyponatremia, we have to always calculate the osmolality. That is very important. We have to find out whether it's a low osmolality, normal osmolality, or high osmolality. High osmolality is a pseudo hyponatremia. So can calculate the osmolality 2 into sodium plus glucose by 18, blood urine nitrogen by 2.8. Normal osmolality is somewhere around 275 to 290 milliosmol per kg. So you can get the osmolality in some of the ABG machines itself. You can get the osmolality. Some labs will provide osmolality values, or we can calculate the osmolality value. So hyponatremia, basically they are divided into three important one is low serum osmolality or actual hyponatremia or true hyponatremia. Other one is normal serum osmolality, high osmolality. That should not be treated with correction of sodium. So hyperlipidemia, hyperproteinemia, hyperglycemia, mannitol, all these things will produce pseudo hyponatremia. So first investigation in hyponatremia is plasma osmolality. Second investigation is urine sodium. When our sodium levels are very low, kidney will try to retain sodium in our body. If there is hyponatremia, kidney will not release any amount of sodium through the urine. So the levels are very low, less than 20 milliequivalents per liter is the levels when the sodium levels are low in our body. If it is more than 20 milliequivalents per liter, that indicates there is a urinary sodium loss like SIADH, salt wasting nephropathy, diuretic therapy, hypoaldosteronism. So these are the conditions which can produce renal loss of sodium. And that most important is SIADH. SIADH you get more than 20 milliequivalents, sometimes it will be more than 40 millioccurrence per liter. Salt wasting nephropathy, you get salt and other electrolyte also will be losing through the kidneys. Next one is urinary osmolality. We can get the urinary osmolality from the lab. If the urine osmolality is less than 100 milliosmolar per kg, it is polydipsia and normal water excretion. More than 100 milliosmolar per kg, that again indicates there is loss of sodium through the kidneys. That is more in favor of SIAD, syndrome of inappropriate antidiuretic hormone. So these are the three important investigations we have to do in hyponatremia. So serum osmolality will tell you whether there is true hyponatremia or not. Second thing is urine sodium and urine osmolality, that will tell you that whether the patient is losing sodium through kidney or any other route, or patient is not taking adequate salt in the past. Hypotonic hyponatremia, that means low serum osmolality. In that we have already seen that three important things: hypovolemic hyponatremia, euvolemic hyponatremia, hypervolemic hyponatremia. In that we can leave that hypervolemic hyponatremia, because hypervolemic hyponatremia we are not targeting the sodium, we are only targeting the volume. We have to reduce the volume, that will make the sodium levels normal. Other two important conditions are hypovolemic hyponatremia, in that the main cause is severe diarrhea and vomiting. We have to replace the water. We have to replace water with normal saline, that will correct the problem. Then renal volume loss due to diuretics, cerebral salt wasting, adrenal insufficiency, or skin can be an area which can lose water and sodium by burns or increased sweating, like sunburns or hyperthermia and all. Euvolemic, main thing is SIADH. Again, isotonic hyponatremia and hypertonic hyponatremia, we already seen that. We will not be discussing that here now. You can see here plasma osmolality low means true hyponatremia. In that again we have to see the ECF volume. If it is increased, then all failures come into picture. If it is decreased, means it's a urinary loss of water and sodium. Again you can see that whether the patient is having increased urinary sodium loss. If it is increased sodium loss more than 20 millioccurrence, it is salt wasting nephropathy, diuretic therapy, or hypoaldosteronism. If it is less than 20 millioccurence, then it is not renal loss, it is due to diarrhea or vomiting. Now if ECF volume is normal, then it is SIADH. You have to rule out the causes for SIADH. Remember, in SIADH there is water retention, but there is no extracellular volume, there is no clinical edema. That is very important. When we learn, we will understand that there is volume accumulation in the body, but clinically you are not finding, because there is no extracellular volume accumulation. So when we are talking about the management hyponatremia, if hypovolemia with dehydration, we have to correct both salt and water. If there is hypervolemia or edema, you have to remove the fluids by fluid restriction, salt restriction, diuretics. Normovolemia, you have to give like SIADH. Again, the treatment, we have seen that it is a water retention, but clinical edema is not that. So initial treatment is always water restriction. Then we can use drugs like Vaptans, tolvaptan, we'll discuss afterwards. Now in sodium deficiency, we have to, most of the patients we have to give oral salt. So we should know how much each teaspoon contains sodium chloride. It contains around 6 grams of sodium. Normally we take around 6 to 8 grams of salt in a day. So additional 6 gram means that much amount we have to add to the diet, either to the diet or orally or through Rayleigh tube, or you can make it capsules of sodium and give to the patient. So additional 2 gram means one third of the teaspoon can be given. So normally 1 teaspoon contains 6 grams of sodium. Now, if we are giving salt in a patient who is already edematous, like cardiac failure, liver failure, renal failure, that salt, we know that there is no actual deficiency in sodium because the water is more, sodium is shown as a reduced sodium level. If we are further giving salt, what happens is salt will again retain water. So the levels of the sodium will further go down because more water accumulation occurs after sodium therapy. So never give sodium in a patient who is having hyponatremia due to hypervolemia. Now we can give normal saline in patients with 0.9 normal saline in patient who is having hyponatremia with hypovolemia. So you can see here the amount of sodium which is there in each 1000 ml each type of fluid. You can see 0.9% sodium chloride and DNS contains 154 milliequivalents, whereas 3% sodium chloride contain 513 milliequivalents, 513 milliequivalents in 1000 ml. So sodium chloride or normal saline is available as 500 ml bottle that contains half of this 154, that is 75 plus 2 77 milliequivalents, whereas 3% saline is available as 100 ml bottle that contains 51.3 milliequivalents. Other fluids also almost similar, like ringer lactate 130 milliequivalents and 0.45% sodium chloride 70 milliequivalents. Like that we can get various. And one important thing is soda bicarb that contains very high levels of sodium. So we should never try soda bicarb in a patient who is having failing heart, because unless until there is a strong indication, we should never give soda bicarb because it can reaccumulate fluid again and again after giving high dose of sodium in a patient who is having fluid overload. Now 3% saline we can give in a patient who is having hyponatremia, who is not getting corrected. It is not getting corrected with traditional methods like oral salt, normal saline, water restriction, all these things. If the patient is still symptomatic, then we can give 3% saline. But before that, we have to calculate what is the deficit of the sodium in a patient, like desired sodium minus serum sodium, patient sodium, into 0.6 into body weight in kg. So that will give you the required sodium in that patient. When we get required sodium, we can easily calculate how many bottles of 3% saline is required, and it should be treated only over 24 hours. So very slow correction only required. If there is a high amount of sodium requirement is there, if the patient is not that clinically bad, we should give sodium chloride infusion in a very low dose, like 10 to 15 ml per hour. That is enough, unless until there is no major emergency, like a patient is having severe coma or acute seizures. We should not try to correct sodium very fast. We should correct very slowly. For example, a 50-year-old male patient, 70 kg, with sodium levels only 110 milliequivalents per liter. There is no peripheral edema, there is no other features, but we have to correct this problem. So desired sodium in 24 hours should be only 122 milliequivalents per liter, because we can correct only 8 to 12 milliequivalents in a day. That's all. We should not correct more. If you correct more, there will be a problem in the brain that is called as central pontine myelinolysis. So we will be correcting, we will calculate the sodium deficit for 24 hours, that is 122 minus 110 into 0.6 into 70 kg. So that will give 504 milliequivalents. If it is 504 milliequivalents, we need at least 1 liter of 3% saline, that is 10 bottles of 3% saline. So 100 ml 3% saline, 51 milliequivalent sodium. So 504 by 51 will give 9.8 bottles, around 10 bottles we have to give. So you can slowly correct the fluid over 24 hours. And remember, if it is severely symptomatic, we can give this much 40.8 ml per hour correction can be given. But if the patient is fully stable, not having any neurological problem, we should only correct half of the amount. So we can give safely 15 to 20 ml per hour can be given for next 24 hours. Rest of the things can be corrected next day. And fast correction is not required unless until there is emergency. And we can also give oral route also. We can try the oral route also. We can give IV correction. Along with that, we can try oral correction also, because advantage of oral correction is oral corrections normally will not create much problems in CNS. But IV correction can, if it is very quick, very fast, sometimes patient can deteriorate because of the correction. But however, every 6 hours we have to see the serum sodium levels, and it should not shoot very fast. And over 24 hours we have to correct maximum 8 to 12 milliequivalents per day. So over 24 hours the correction can be maximum 8 to 12. So every 6 hours we can go a correction like 4 or 5 milliequivalents increase. That's all. So we should be very careful in correcting sodium. But in severe neurological symptoms, like patient is having deep coma or seizures, we can give 3% saline 100 ml over 10 to 60 minutes, 2 ml per kg per hour, up to maximum of 100 ml can be given, and repeat the dose if the patient does not improve. So that can be given. If we don't correct slowly, if we correct very fast, patient can develop a problem, that is osmotic demyelination syndrome. So if you correct fast, patient can develop either central pontine demyelination or extra pontine demyelination syndrome. Demyelination syndrome can have dysarthria, dysphagia, flaccid quadriplegia, pseudobulbar palsy, and coma. Sometimes seizure also develop. So we should be very careful in correcting hyponatremia, especially when it is chronic hyponatremia. Acute hyponatremia with severe symptoms can be corrected fast, like 40 milliequivalents over 40 milliequivalents per hour for 24 hours can be given. That calculation we have seen. But in a chronic hyponatremia, we should correct it very slow. You can give 15 to 20 milliequivalents per hour only. Now SADH, the treatment is slightly different. We have to control the water intake. Water restriction around 1 liter per day. Diuretic can be given. Furosemide can be given. Sodium can be given as oral salt. If that is not getting corrected, in emergency we can use 3% saline. Otherwise, we have a drug that is tolvaptan or conivaptan. They are vaptans. They are vasopressin receptor antagonists. Normally we use tolvaptan. 15 milligram once daily is enough in most of the patients. Some patients may require higher dose, like 30 milligram per day. And when we are giving tolvaptan, we have to monitor the liver function test. That is also very important. So we have discussed about hyponatremia in detail. But in emergency room, hyponatremia means most of the patients will be sick. They are very weak. They have neurological symptoms. They can have seizures. So sometimes we have to correct it very fast. But if the patient is not that symptomatic or mild symptomatic, don't try to give 3% saline in a faster rate. That will produce more complications than benefit. In a patient who is having hyponatremia because of severe water loss, like diarrhea, vomiting, try to correct it with normal saline. That is the safest method of correcting hyponatremia. If the patient is having symptoms, then you can try 3% saline. A safer range will be 10 to 15 ml per hour in an adult patient. In a child, we have to calculate and give. But adult patient, 10 to 15 ml per hour will be a safer level. And if the patient is having symptoms of hyponatremia, up to 40 ml per hour can be given. But every 6 hours we have to monitor the sodium levels, and it should not more than 12 milliequivalents in a day. That is also very important. Only if the patient is having seizures and all, we have to correct it fast, that we have seen the correction rate. Thank you.